So, good morning, everyone. After that wonderful talk about intraoperative complications, I have been given the topic by Karan to talk about postoperative management and complication in 6 minutes. So that I don't think I will be able to give justice to that, but yeah, I'll try. So, doing the penetrating keratoplasty surgically is a very important and very highly skilled surgery, but post-operative management is going to decide the fate of the graft. So that is also as important and very important for every cornea surgeon. So post-operative management actually changes with time. So in initial 24 hours, when you have just done the graft and you will be looking for wound integrity, you look for any loose sutures or leakage, and obviously you always have to be watch out for any infections which can happen in early and delayed and very late post-operative period as well. Early post-op IOP generally high because of OVD use or retained OVD or because of inflammation as well, and you need to control that with topical medications or systemic according to the IOP level. So this is generally the post-operative regimen. No financial interest. Just to give you an idea that these are the medication we give in post-operative period, but depending on the indication of the keratoplasty, we would change our medication whether it is therapeutic or optical stuff like that. In first 7 days, generally the reepithelialization of the donor cornea and the host epithelium grows over the donor, and that has to be checked. And if there is any delay in that, it also has to be, you need to look for the reasons why it is happening, like dry eye or any trichatic lashes, which is hampering the epithelialization. Inflammation control is very important because it will lead to high intraocular pressure, and it can also lead to graft failure as a secondary complication. Always watch out for infections and prevent and manage early complications, which I am going to talk about in the later part of the talk. And once the graft survives at least a month or so, then there is always a chance of having graft rejection. So you need to be careful with the examination. Always look at the endothelium site very carefully, because endothelial rejection is one of the most common we see in post PK and even post endothelial keratoplasty. It can happen. So in a late part, I think sir is going to talk, Vogla sir is going to talk about astigmatism and visual rehabilitation of the patient. So early postoperative complication, what we commonly see, especially while learning, when we are also learning, we say wound leak or wound displacement. So if it is associated with the shallow anterior chamber, it has to be resutured, and if there are loose sutures, and SE formation has to be done. If there is any iris prolapse, it also has to be taken in the OT. But if the SE is formed, there is a micro leak, you can manage it with the bandage contact lens or just a pressure patch. Persistent epithelial defect, it has to be, look for why it is not, the epithelium is not growing. There are multiple reasons why it can happen. So look for dry eye disease or limbus stem cell deficiency, which can be there pre-existing. And medical management involves profuse lubrication. And if it doesn't work, then you need to think about options like amniotic membrane or SLAC. If you have done a graft where previous history of herpetic keratitis is there, or you are suspecting a herpetic infection, then oral antiviral has to be given post-operatively, because that is also one of the most common reason for having a persistent epithelial defect. Any graft host junction abnormality, if your junction is not proper aligned, then obviously epithelium will not be able to grow, and that has to be surgically corrected. And any lid abnormalities like exposure or trichiasis has to be corrected surgically. Suture complications is also another issue we all face. Most commonly, sometimes the unrotated suture and not exposure, which can be just rotated on the slit lamp using a tying forceps. Any broken or loose suture, if the graft host junction or the healing and scarring has happened, you can just remove it, or it needs to be replaced with another suture. Suture infection is one of the most dangerous complication. I feel that it can completely just damage your graft, and you can the whole purpose of the penetrating keratoplasty can be into vein. And there are certain immune infiltrates we see in early postoperative period, which generally goes with time, and generally in immune infiltrates there is no epithelial defect associated with it. So the post-operative, this is one of my grafts which had very multiple loose sutures, and there was a graft infection with the corneal epithelial defect in that area. So all suture had to be removed, and the medication was changed. Post-operatively, steroids were stopped, and actually the graft survived, but the healing was there with the scarring. I'm not going to talk about post-op glaucoma management, which is going to be covered by Dr. Shivani. Inflammation is another reason where graft generally goes into rejection and ultimately fails. So inflammation has to be controlled with steroids, but steroid is always a double-edged sword, so it has to be used very carefully. So anterior synechia formation is also common in the periphery. If I had recently done a graft where the peripheral anterior synechia was exactly at the graft host junction, and that graft ultimately went into rejection. So that has to be taken care of intraoperatively. and posterior synechial formation leads to pupillary block and secondary high IOP and then glaucoma. I had a case where hyphema happened on the day 3rd, and I watched it, and then it happened again on day 5. I think Karan might remember, it was a case in Sitapur. So we did a, systemic evaluation, and he had multiple liver-related issues, and his blood profile was deranged, and that's how we came to know he was having recurrent hyphema. So this is the therapeutic graft where you can see the pupil is completely occluded, but I did I always do two surgical PAs taught to me by Dr. Karan, so it actually prevents any high intraocular pressure. And this is the graft where on the post-op day 1 there was a full, I put a air bubble in the anterior chamber, and there was it was okay. And the day 3 that was full chamber hyphema. So it has to be washed depending on the level of hyphema. Graft infection is a dreadful complication. So early graft infection can be because of donor contamination or suture-related issues or incomplete excision of the host when you are doing for the therapeutic purpose. So certain risk factors which can happen, which can lead to graft infection is like told that persistent epithelial because of herpetic infection or prolonged use of BCL. Sometimes we forget to remove the BCL. So many times it happened, and patient has immunocompromised, then there is a high chance of acquiring any infection. So whenever graft infection is there, you need to stop or reduce the steroid. I would like to discuss that with our senior panelists here, that do you just stop the steroid when the graft infection happen, or just reduce it, or switch to a low potency steroid. Meanwhile, we are getting the cultures and switching to other fortified medications depending on the organism we find. So this case I've been handling since March 2022, and initially she had a graft rejection which was managed, and after that she also had graft infection in the same eye. Some kind of capsaicin said fall in her eye, and then she had a ulceration in that area, which was managed medically. But you can see there was a healing with minimal scarring was there, but there was a thinning in the cornea in that area. So and primary graft failure. So when the primary graft failure happens, it generally requires either regraft, or you can just remove you can do a non-stripping DSEC also. So most common reason is pre-existing poor donor endothelium. Surgical trauma is also another cause, where if you are learning and you damage the endothelium while managing the tissue intraoperatively, that can also be the reason. So to prevent that, you generally want to use a more than 2000 endothelial cell count graft for optical purposes at least, and use generous OVD, especially with sodium hyaluronate and chondroitin sulfate. So graft rejection is a late complication. There are various risk factors which can lead to graft rejection, including younger patient, large graft, eccentric grafts, and if there is a more than 2 quadrants of corneal vascularization. Recently, there are reports of graft going into rejection after COVID vaccination. I think Sir has also shared his case of DMAC going into rejection, I think. So I would like to know Sir's views and other panelists' views.
I have seen after
Botox injection. That's new for me. So, in Sitapur. Okay. So, I still, there are articles, but we are yet to figure out why exactly still it happens. So this, whenever there is a graft rejection, the corneal thickness increases. That is you can, if you are doing OCT on a routine basis, which I do for my graft because of the availability, and you can see the corneal graft had increased thickness when it went into graft rejection. In the previous visit, it was only around 540. So graft rejection can happen just epithelial rejection or a stromal or endothelial rejection. Endothelial rejection is one of the most common we see in post-PK, and there is a typical finding fast. Okay. There is a Codadus line we see, and so for graft rejection, the steroid is the management. All form of steroid you can give, and cyclosporine is also debated role. I would like to know the views. So. To conclude, for whenever you are managing a post-PK graft, close follow-up is very important initially. You have to watch out for infection and always balance the steroid use. And if graft rejection happens, it does not mean the graft has failed, so always fight for it. Thank you.
when you're using cyclosporine
Sir.
for graft rejection, the dose is the orosporin, which is 2%.
Okay, sir.
No commercial interest with Madurai group, but 2% is what you would use. The patient